My dear friends, the question that I am going to answer today in the next 15 minutes is, does PCOS increase the risk of cardiovascular disease? Now, as we all know, probably insulin resistance is the crux of the matter. Because even though insulin resistance is not part of the diagnostic criteria for PCOS, it is seen in about 95% of obese women with PCOS and about 75% of lean women with PCOS, telling us thereby that it seems to be, at least in part, independent of obesity. Insulin-resistant and hyperinsulinemia are well known to increase the risk of CVD, not only in PCOS, even otherwise. They are well known to increase the risk of cardiovascular diseases. However, studies on the degree of CVD risk in women with PCOS versus general population shows a mixed bag. Contrary to what we believe that there should not be any confusion, there is some confusion if you study the degree of CVD risk in PCOS versus the general population. It is generally accepted that the CVD risk in PCOS is explained by the traditional CVD risk factors, and the absolute risk conferred by PCOS is not very high. However, it must be understood that the CVD risk is not uniform across all women with PCOS diagnosis. It depends on the phenotype of the PCOS. It depends on the ethnicity of the PCOS woman. So it is greater among certain PCOS subtypes and certain ethnicities also. For example, Hispanic PCOS women have a more severe phenotype, and non-Hispanic Black women have probably the mildest phenotype. Hyperandrogenic and anovulatory phenotype is probably the most insulin resistant, with more of BMI and more of central adiposity. Okay, with that introduction, let me now come to the CVD risk factors in PCOS. Let me start with dyslipidemia. The dyslipidemia in PCOS is characterized by elevated triglyceride, elevated VLDL, and low HDL cholesterol. LDL may be elevated, but not very high. This is the classic atherogenic dyslipidemia or diabetic dyslipidemia, which is usually associated with insulin resistance. So the LDL concentration is not very high. It can be normal or maybe borderline high. But the quality of the LVL, unfortunately, is very bad. The LDL predominant is the small, dense LDL, which is much more atherogenic than the large, buoyant LDL, which is less atherogenic. So in PCOS women, even though LDL is normal, the small, dense LDL particles predominate. Similarly, the oxidized LDL, which is more of a malignant form to produce atherosclerosis, is in higher concentration in these people. Next CVD risk factor, equally important, is glucose intolerance and diabetes mellitus. Approximately 35% women with PCOS have impaired glucose tolerance, whereas about a tenth, in fact 7.5 to 10%, have type 2 diabetes mellitus. On the other hand, conversely also is true. If you take women with type 1 diabetes or type 2 diabetes or gestational diabetes, the prevalence of PCOS is increased in these people. And it is also related to obesity, because as obesity increases in PCOS, there is a substantial increase in diabetes mellitus also. However, it must be understood that even among lean women with PCOS, there is increased risk for diabetes mellitus. This position statement from the European Society of Endocrinology recommends oral glucose tolerance test in all obese PCOS women. In lean women, again, oral GTT is recommended in those who are above the age of 40 years, with a positive history of gestational diabetes or a family history of type 2 diabetes mellitus. There is no routine recommendation for doing either insulin concentration or the indices of insulin resistance, nor is there any recommendation for using HbA1c as a screening test. There is no evidence, unfortunately, on when exactly we should screen these people. But as a consensus, it is arbitrarily suggested that these women should be screened every 3 to 5 years, even if they are not a diabetic. Next important CVD risk factor is hypertension. And like diabetes and dyslipidemia, it has got a high prevalence in women with PCOS, 65% compared to 41% in control. Hypertension in PCOS is not associated with BMI. It is actually the result of renin-angiotensin-aldosterone system activation, basically increase in aldosterone, a hyperaldosteronic state. Not only is hypertension more prevalent in PCOS, but the quality of hypertension or the variation in hypertension is also different. Normally, there is a nocturnal dip in hypertension in a normal person, whereas in PCOS, it is found that as far as systolic BP is concerned, 51% do not show the nocturnal dip, and as far as diastolic BP is concerned, 23% do not show the nocturnal drop. The PCOS during reproductive age confers actually a higher risk of hypertension even in the post-menopausal group. Overweight and obesity, the next important risk factor, is very, very, very frequent in women with PCOS. Not only is overweight BMI, but the waist-hip ratio is also higher in these women. And this all metabolic aberration, whether it is diabetes, hypertension, or dyslipidemia, worsen as the woman becomes more and more obese. And it can be attributable to the underlying insulin resistance. Metabolic syndrome, which is defined by the presence of any three of the following, which is elevated waist circumference, 102 in men and 89 in women, triglyceride more than 150, HDL less than 40 in men and less than 50 in women, blood pressure more than 130 systolic or 85 diastolic, and elevated fasting glucose of more than 100. If you have more than 3, you are classified as metabolic syndrome. And the prevalence, the odds ratio for prevalence for metabolic syndrome is 2.88 in women with PCOS, which means about 3 times higher than the general population. Of course, like all what I had said, there is significant heterogeneity here also, and the underlying problem probably is insulin resistance. Obstructive sleep apnea. Again, obstructive sleep apnea is not due to obesity alone. Even after controlling for body mass index, women with PCOS still have 30-fold more likely to have sleep disordered breathing. Another less important but CVD risk factor in PCOS is non-alcoholic fatty liver disease. Now, we have been talking about traditional CVD risk factors. Let us look at some emerging risk factors, which is activation of the sympathetic nervous system, which has an adverse impact on cardiac structure and function in hypertension as well as in the general population. And in PCOS, this could be the underlying cardiovascular abnormality in women. Another important emerging risk factor is chronic inflammation. Because arteries get inflamed, there is arterial inflammation in response to injury triggered by LDL cholesterol, cigarette smoking if it is there, and hypertension. And this prolonged persistent exposure to inflammation can lead to subsequent plaque formation and rupture. Oxidative stress, another important emerging risk factor, is an imbalance created by the excess production of oxidants and the lesser presence of antioxidants. The role of reactive oxygen species in the various signaling pathways that underlie vascular inflammation and atherogenesis is also now being increasingly discussed. So this is also found to be more prevalent in women with PCOS. Vitamin D deficiency is also another important emerging risk factor. Do not forget oral contraceptive pills, because oral contraceptive pills are given in women with PCOS because they are effective in reducing hirsutism. They induce regression of male pattern alopecia and restores cyclic bleeding. However, OCPs, remember, deteriorate cardiovascular risk and metabolic profile, and hence use of OCPs in PCOS women is a matter of concern. So we have PCOS, which produces traditional risk factors and emerging risk factors. Traditional risk factors being obesity, diabetes, hypertension, dyslipidemia, and emerging risk factors being activation of sympathetic nervous system, inflammation, oxidative stress, and vitamin D deficiency. All these together produce a subclinical CVD and then clinical CVD. So let us look at subclinical CVD. Probably one of the most studied subclinical target organ cardiovascular damage is coronary artery calcium scoring. And it has been found that it is more prevalent in women with PCOS. Even if you take elderly women with PCOS, coronary artery calcium scoring is higher in this group. Carotid intima media thickness is another subclinical target organ damage, which has been found to be higher in women with PCOS. And then you have pulse wave velocity, which is actually a measure of the elasticity of aorta, which is also higher in women with PCOS. And then you have markers of chronic inflammation like CRP and homocysteine, which are also significantly elevated. Again, let me remember that in all these things, there is a high degree of heterogeneity depending on the phenotype as well as the ethnicity of the woman. And coming to the last important part, that is clinical CVD risk. Unfortunately, or rather fortunately, the evidence is conflicting. We would have expected that with this amount of risk factors, this amount of subclinical CVD, we would have expected significant increase in clinical CVD. But the evidence is conflicting. Does PCOS independently increase the risk of clinical CVD events? Is a question which merits answer even now. There is significant risk factor for CVD, there is no doubt, regardless of the BMI. But it depends on the phenotype of PCOS, and there is heterogeneity, not only in the clinical presentation of PCOS, but also in the CVD risk conferred by PCOS. And that is why probably the reason why there is conflicting evidence with respect to PCOS and clinical CVD risk. This is probably one of the latest studies published in the Journal of Endocrinology and Metabolism. Women with polycystic ovary syndrome having an increased risk of major CV events, a population study. And you can see that if you look at survival, which is the y-axis, and the years from the index date as far as the x-axis, whatever you look at, whether it is a composite endpoint, myocardial infarction, stroke, angina, revascularization, or CV-related mortality, the dark line, which is cases, which is patients with PCOS, comes lower down, or survival is less in them compared to the lighter line, which is actually the controls. The same is true in the sub-study of the WISE trial, which is the Women's Ischemia Evaluation Study, where they found that women with PCOS have a large number of CV events. Multivessel CVD was observed more in PCOS women. Event-free survival, including fatal and non-fatal events, was significantly higher in PCOS women compared to non-PCOS women. And the difference between the two groups became higher when stroke was also included, telling thereby the relationship between PCOS and stroke. So we have these two studies which show that the risk is high in women with PCOS. On the other hand, we also have this large 21-year controlled follow-up study of cardiovascular disease and risk factors in women in the postmenopausal age. And it is interesting to note that if you look at 1987, when the trial started, look at the p-value, the thick p-value numbers for triglycerides are higher, HDL is lower, LDL is higher, and systolic BP is also higher in women with PCOS. 21 years later in 2008, look at the p-values and you can see there is no difference between PCOS and control, except maybe in triglyceride, where there is a slightly statistically significant. All the other risk factors have leveled out between PCOS and controls. You can see the p-values there. With the result that when you look at cardiovascular events, whether it is hospitalization due to MI or aged MI, whether it is hospitalization due to stroke or aged stroke, or all CVD, you can see there is no difference. The p-values are absolutely non-significant, PCOS versus control. Looking at mortality, the story is the same. If you look at the deceased during follow-up or the mean age at death, again, absolutely no difference in the p-values. So, CVD events in aged PCOS patients are similar to those without PCOS or only marginally increased. It is anyhow lower than what was expected on the basis of risk calculation during the younger age. This discrepancy is, however, very difficult to explain. The mechanisms are unclear why there is a lot of CVD risk, but the events are less in patients with PCOS. Maybe there is progressive normalization of risk factors during late reproductive age, as was shown in the last study, where the risk factors became same by 2009. Moreover, in the majority of cases, the severity of PCOS reduces during lifetime due to spontaneous reduction of ovarian and adrenal androgens. Risk factors are more, there is no doubt about it, and they cluster in PCOS, but PCOS becomes milder with increasing age and probably disappears later after menopause. The cardiometabolic abnormalities, however, it has been found, can exist or can prolong beyond the onset of menopause. But it was also found that women with PCOS enter menopause at a later age, and that could be a protective effect on the development of atherosclerosis and the risk of future events. So it is very difficult to explain, but there are umpteen mechanisms. So my dear friends, ladies and gentlemen, let me conclude here by trying to answer this very difficult question. How is it possible that so many risk factors for CVD cluster in PCOS at an early age, yet does not seem to translate to an increased risk for CVD in later life? Well, the first part is correct. There is early worsening of risk factors, but it does not seem to progress. That is a fact. It could be that women are aware of these risk factors in early age, take action, and so anticipate the events, and so reduce the risk factors. Whereas in the control group, they develop metabolic abnormalities gradually over time and end at a similar level as women with PCOS, as we saw in the last study. Moreover, there has been genetic variation in PCOS women, so that they have a later menopause, they have a better DNA repair and maintenance, and that could possibly explain the reduced cardiovascular event rate in PCOS. So risk factors are more, it is a fact, but event rates possibly is less. There is still, as I said, some trials showing that the event rates are high, but the evidence is conflicting. So I conclude here, and thank you very much for the opportunity for me. Thank you.